Case is 56-year-old male Sundaram. He is a follow-up case of supracondylar femur fracture with knee spanning external fixator, posted for external fixator removal and cast application under general anesthesia by Dr. Joshi. Over to Dr. Joshi. Thank you.
Good morning, Dr. Girish Joshi. We are indeed very happy and fortunate to have you with us this morning. And I'm sure that you traveled a long distance, but I think you are well rested and all set to demonstrate to us. Over to you, sir.
Thank you. Thank you all, and I'm happy to be here. Thank you for the invitation. So for this particular patient, obviously there are several ways of doing a general anesthetic. This is fairly a quick surgical procedure, but just for demonstration purposes, what we are going to do is a general anesthetic with endotracheal intubation. And we are also going to use a BIS monitor just for discussion's sake. Typically what I do is as soon as the patient comes into the OT, I give them fentanyl, and the dose of fentanyl is typically about 1 microgram per kilogram, ideal body weight. So what we did is we gave 50 micrograms of fentanyl, and then we put the monitors on. The key is to give at least fentanyl at least 3 to 4 minutes before you start your induction. So now we are pre-oxygenating the patient, and there are a lot of ways of confirming optimal pre-oxygenation. The best way is to basically look at expired FiO2, and you know, you don't have it here, but that's another way. Expired FiO2, expired. Yeah, so you have inspired and expired. What's the flow rate of oxygen? You can increase it a little bit. So now obviously you have to ask him to take deep breaths. Slow deep breaths. We have our BIS monitor just for presentation, and the BIS is around 97, as you see, which is obviously an awake state. And it's been about 2-3 minutes before, for the fentanyl, correct? So we can start our induction, and the induction dose of propofol is just a sleep dose.
Sir, when you say a sleep dose...
so sleep dose, so what do I do normally? You calculate around 1 to 2 milligram per kilogram, but give slowly. And you have to keep encouraging him to breathe. Because of that fentanyl, they basically hold their breath normally.
Bala, do they do anything to prevent the irritation of propofol there? Just ask him.
Yes, so I would use lidocaine or lignocaine, about 10 to 20 milligrams. But if you give fentanyl ahead of time, as you notice, he has not much of pain from propofol. Yes, so he's asleep, and see the BIS is going down, and obviously now we are going to be giving your atracurium. Go ahead and give atracurium low dose, because it's a short surgical procedure. And then what you do is once... Go ahead. 25, 30 milligrams is fine, yeah, that's good. And then we are going to have a dial concentration of deslorelin at 3%, which is... Here. So you want to turn the dial concentration of deslorelin at 3%. So there's a reason why I'm using 3% and not more, and that is because typically what usually happens in the old days, we used to have a higher concentration of inhaled anesthetic, whether it be sevoflurane or deslorelin, and typically we would have about 1 whole MAC. As you see, the sleep dose of propofol brings the BIS down to 35 in 95% of cases. And by giving half a MAC, all you're doing basically is, as the propofol is wearing off, the inhaled anesthetic basically comes on. In the old days, when we used to use a full MAC of desflurane, that is 6%, the BIS would remain very low. Typically, you want to maintain the BIS around 50 or so. So you will notice as the desflurane concentration is being built up, that BIS will gradually go up and then settle down at 40. No change in heart rate, no change in blood pressure, so obviously it's very stable. And you can intubate whenever you feel comfortable.
So there's a question about connecting to the end-tidal carbon dioxide, EtCO2.
So whenever you're comfortable, you can intubate. So while he's doing that, I'm going to just repeat the steps. Ideally, you want to give fentanyl at least about 3 to 5 minutes before your propofol dose. That will allow you to decrease the dose of propofol and also decrease the pain from propofol. Then I would give about 20 milligrams of lignocaine and then obviously the sleep dose of propofol. After that, we give muscle laxant. Again, comparing old times with new times, in the old days, we used to do what's called as a test dose before giving the muscle laxant. You basically attempt and see if the patient can be ventilated. We do not do that anymore. In fact, it's not necessary and there's more harm to the patient. So we don't do test dose of propofol. Test dose of bag ventilation. So if you notice the BIS monitor, you can see the BIS is gone up a little bit, and that is typical. And I will give you that information in the lecture as well. The dose of the stimulus from the surgical procedure, including intubation, correlates very well with the BIS. You can add nitrous oxide. 50-50. Yeah.
So do you still use nitrous oxide?
Yes, I love nitrous oxide. There are so many benefits of nitrous oxide. And unfortunately, about a decade ago, the so-called Enigma study demonized nitrous oxide. But now we have the Enigma 2 study, which basically showed that nitrous oxide is beneficial. For ventilation point of view, we will set the ventilation at about 7 mils per kilogram ideal volume, as we talked about, say maybe 500 mils, and that's the tidal volume, and then the rate will be set to achieve an end tidal concentration of CO2 around 40. Again, I'm going to compare and contrast as to what we used to do once upon a time and what's been recommended from recent research. Now, once upon a time, we would maintain the end tidal CO2 around 30 to 35. Now we are recommending that you keep the end-tidal CO2 slightly higher. So can you decrease the respiratory rate to about 8? Respiratory rate we're bringing down to 8 because the end-tidal CO2 there is a bit low. So we want the end-tidal CO2 around 40. That means the PA CO2 be about 40 to about 45 or so, and that improves the perfusion of organ. Now look at the BIS monitor. See, the BIS is quite normal, 40, and we want to maintain between 40 and 60. So you saw the BIS had temporarily gone up. That's the stimulus from the intubation. That doesn't mean he was really awake at that time. And I will share with you in my lecture how there is a good correlation between the stimulus, whether it be surgical stimulus or stimulus from an endotracheal tube, and the BIS goes up. But typically, at least with the intubation, the duration of that increase is fairly short, maybe about 2 minutes or so. So now we are maintaining oxygen 50%, nitrous oxide 50%, and desflurane. And what we are going to do is I also want to show you the end what's the MAC value? MAC.
Dr. Joshi, do you spray the cords before you intubate normally?
No, I'm assuming you're asking spray with lignocaine, correct?
That's right.
Yes, no, there is really no reason to spray. In fact, in the old days we used to do that. Now there's good data to suggest that A, it's not necessary. As you see, the blood pressure has not changed, the heart rate has not changed. And that spraying itself can actually stimulate the cords and cause more increase in blood pressure and heart rate, hemodynamic stimulation. And it's actually not necessary. So we have now fairly well maintained with our end-tidal CO2, which is around 40, so the ventilation is good. It's called as lung protective ventilation. Our heart rate, blood pressure is good, patient's fairly stable. The BIS is normal, and basically by this time the surgeon would have started. We wouldn't be waiting for all this. The surgeon would have started, and where's your twitch monitor? Yeah, please. The surgeon can proceed, yes. And typically you wouldn't be waiting so long. We would be going on fairly quick. So he's now in for maintenance phase. All you need, as you see, only about half a Mac of your inhaled anesthetic. Typically, if you're using nitrous oxide, you need about 0.8 Mac. Where is the Mac value? Minimum alveolar concentration. If you don't have it, it's okay.
Bala?
Yeah, come down the flow to
with your permission,
0.5 and 0.5. The total flow is at the most 1 liter. Typically, I would go down even further. So we are going to monitor the train of 4 response, or you have the 12 card? Okay, we can just monitor train of 4 response. Maximum 70. So we are going to use maximum, obviously, twitch. How much total atrocurium did you give? 50? 50. Yeah. No twitch. Train of 4 response. So if you see the twitching, you have the fingers twitching. What I'm looking for actually is the thumb twitching. Many times you have the finger twitching and we saying, oh, patient's back, but that is actually a wrong response. So I'm looking for the thumb, the adductor pollicis movement. And once you get that, that means you know that that's the twitch you're looking for. So let's do another, is that the maximum 50 MA? I would go to 70. Okay, that's what you have, okay. No, not double burst. Train of 4. Okay, yes. Yeah, he's got a little bit of twitch, so maybe 1 twitch, and that's fine. Atrocurium is fairly quick. He should come out. If not, we'll talk about reversal. Yeah. You had good. Yeah, don't change. Perfect. So I just want to emphasize that when we use what's called as lung protective ventilation, that means the tidal volume is about 6 to 8 mils per kilogram ideal body weight. We have to add PEEP. If you do not add PEEP, in fact, you could cause basal atelectasis, and that. So we have a PEEP of 5, which is good enough. And the rate, so your tidal volume is fixed at 6 to 8 mils per kilogram ideal body weight, your PEEP is fixed, and the rate is adjusted to achieve the end-tidal CO2 around 40 or so. And I'm happy with this end-tidal CO2. And we have, as you notice, the dial concentration is 3, and the BIS is still around 40 to 60. You will notice when the surgeon starts, the BIS may go up a little bit, so we may have to adjust our concentration of desflurane. But for now, everything is good, and we now just wait for the surgical stimulus.
Are you using low flows?
Yes, we're using, actually, by definition, low flow is less than 1 liter total, or even less, maybe 500, but right now we're using 1 liter total low flows. I could easily go down, but that's what we're using, 1 liter. So relatively low flows, not the physiological low flow, which would be about 250, 300 mils. But we are using low flow easy, yes.
Dr. Joshi, I have a question.
Sure.
Of course, this monitor doesn't display that. Do you use age-adjusted minimum alveolar concentration for inhaled anesthetics?
I couldn't hear you. I'm sorry. What did you ask?
Do you use age-adjusted
MAC values?
values.
Absolutely. So the monitors, I don't know about this Philips monitor, but the monitor we have typically, when you look at the MAC value, the default is for a patient who is 40 years old. And for every decade increase in age, there's a 7% drop in the MAC requirement. So yes, ideally, before we get started, if I had an older patient, I would put the age of the patient in the monitor so it will automatically adjust the MAC value for me. But if, let's say, your monitor doesn't do that, it is for 1 decade, 7% reduction in MAC value.
And just to follow up on the same question.
Sure.
Do you see an increased requirement in MAC if you are using a spontaneous ventilation technique for desk flow rate?
Do I see an increased requirement?
Yeah.
Of MAC what? The latter part of the question, please.
May I repeat that? Do you see that you need an increased end-tidal concentration of desk flow rate when the patient is breathing spontaneously?
Not really, no. In fact, when the patient is breathing spontaneously, the patient will adjust. That's the benefit of having a patient breathing spontaneously. The MAC values would remain the same. It all depends whether you're using nitrous oxide, so keep in mind nitrous oxide adds to your MAC, and the amount of fentanyl you're using. As you notice, we just gave 50 micrograms of fentanyl at induction. That is because this is not a painful procedure. Let's say if the procedure was painful and I had a patient breathing spontaneously, I would give fentanyl and titrate the fentanyl to the respiratory rate. But the MAC remains the same, whether they're breathing spontaneously or they're being ventilated.
Thank you, Dr. Joshi. Thank you.
Dr. Joshi, do you use Midazolam anytime in pre-medication?
Yes, and as you notice, I didn't mention Midazolam here at all because we did not use Midazolam. And in my lecture, I will show you that recent data suggests by giving benzodiazepines prior to surgery, there is a delayed in recovery, and definition of recovery in this paper was basically time to extubation, and also it increases the incidence of post-op cognitive dysfunction, even in relatively healthy younger patients. So as a habit, we should not use any pre-medication as much as possible. The other thing, now that you're asking about it, I just want to mention, the other thing I see in my travels here in India is people use either atropine or glycopyrrolate as pre-medication. And really there's no reason to do that. In fact, that is even worse than giving Midazolam. So I hope that the practice is changed now in India slowly, hopefully faster. We used to do that in older days when we used halothane and there was concern of bradycardia with halothane. But there is no such concern anymore. Even if you have a little bit of secretions, it's not a big deal. And so I would recommend that you stop using any antisyllog or anticholinergic drugs such as atropine or glycopyrrolate and use Midazolam only in very selective patients. And that selective patient population is those who are extremely nervous patients, because we do know that anxiety, pre-op anxiety, is related to bad post-op outcome. So that's why we didn't use any Midazolam. He was very comfortable. We talked to him before the procedure, and I found that he was not that anxious. There was no reason to give any Midazolam.
Would you use that at least in a long surgery procedure, say 3 hours or 4 hours?
No. Again, in fact, for longer procedures, giving that Midazolam would be only for anxiolysis preoperatively, but talking to the patient does, much more wonders than giving Midazolam. Allaying anxiety of the patient it means that you talk to the patient, explain to them what's expected. So example, they come into the OT and they see all this, 10 people trying to put monitors on, the lights and all. So you explain to them very briefly, it doesn't take too long, that look, that's what's going to happen, so don't worry about it, we'll take good care of you, etc. I would recommend to avoid the use of benzodiazepines as much as possible prior to surgery.
Hello, sir. Just 1 second. One small announcement. We have the plasma screens put up in the food court, and the tea is being served. If you want, you can watch everything from there as well, because the session will start at 11:15. Wanted to utilize this 15 minutes for you to have the tea and also watch the proceedings from the food court.
Increase your desk line, right?
Yeah, go ahead. Yes.
Hello, sir. Hello, sir. It looks quite advanced. You've used the BIS monitor. You've used desflurane. It's a short procedure. Couldn't you have done away with an LMA rather than an endotracheal intubation? And
correct. Yeah. So that's why when I got started off, in fact, there were two ways. I mean, this is a very short procedure, as you say. We could have just held a mask, not even an LMA. You could give the same technique, a little bit of fentanyl, propofol, mask ventilation, patient breathing spontaneously. But because we have that demonstration phase, we thought we'll get you the benefit of the muscle action, show you that stimulus can increase the BIS, but it's not really that the patient's aware. And also, more importantly, we are going to discuss the reversal of muscle action, which I believe is another important thing you will. Yeah, increase the rate. So as you notice, the entire CO2 has gone up a little bit. It's about 48, so we are going to increase the rate to 10 from 8. So basically the aim is to maintain the entire CO2 around 40. And even if you didn't have the BIS monitor, again, this was for demonstration purposes only, you didn't have the BIS monitor, I will share with you the data in my lecture that with desflurane you can safely go by the MAC values, and we have very good data which have correlated the expired concentrations of desflurane with the BIS numbers. And typically, all you need is an overall MAC of 0.8 to 1 MAC, no more than that. And I will share with you that data. But you're right, this could be a very simple anesthetic with just mask ventilation or LMA if you wanted to do that. Intubation is not necessary.
Good morning, sir. Sir, I would like to know your suggestion on adding dexmedetomidine for long duration surgeries.
Yes, so when we got dexmedetomidine when it was fairly new, we were using it quite a bit. Now our use of dexmedetomidine has gone down, and typically we would use it in patients who are morbidly obese, patients who have sleep apnea, where I want to decrease the dose of opioids. The reason why our use of dexmedetomidine has gone down significantly is because we have realized that it's not as short acting as it was meant to be, and therefore we have these patients who remain a little bit groggy postoperatively. Now it has no effect on respiration, so that's not an issue, but that grogginess is an issue. So that's why we are very selective in using dexmedetomidine. Nowadays we use dexmedetomidine quite a bit for sedation cases in morbidly obese and sleep apnea patients, but not as much for patients undergoing general anesthesia. The best way to use dexmedetomidine as a sedative for procedures where you need just sedation is combine dexmedetomidine with ketamine. So what I would do normally is start dexmedetomidine at 1 microgram per kilogram per hour infusion, and when the patient kind of phases out a little bit, I would then give my ketamine about 0.5 milligram per kilogram ideal body weight. So typically it's about 50 to 100 milligrams. And then that's enough for the ketamine, and then titrate your dexmedetomidine dose to the patient response. But as I was saying, we don't use much for general anesthesia.
Good morning, sir. One question for you. What is your ventilation strategies when you do lap surgeries?
Again, for all procedures, whether it's laparoscopy or for open procedures or this kind of closed procedure, we use lung protective ventilation. That means we use tidal volumes around 6 to 8 mils per kilogram and respiratory rate, PEEP of 5 and respiratory rate to achieve entirely CO2 around maybe 40 or so. Let's say because of insufflation, abdominal insufflation, the peak pressures of intrathoracic peak pressures are going up, then you may contemplate to use basically pressure control ventilation. That allows you to basically give the same tidal volume but at a lower peak pressure. So that's another option you could have. If you do that, just keep in mind as the patient's muscle relaxation wears off, the intercostal muscles will contract, and so you would get less tidal volumes for the same peak pressure. So you've got to be a little bit more vigilant. There is data to show that overall there is very little difference in as far as outcome is concerned between volume control and pressure control, even in morbidly obese patients undergoing laparoscopy. So I do not routinely always use it, but when I do have difficulties in maintaining the peak pressure. So if the peak pressures go above 50 millimeters of mercury, then I would basically change from volume control to pressure control.
And so, and during laparoscopy surgeries, we usually see they develop hypertension after some time.
Correct.
What do you do to control the hypertension? Do you use pharmacological drugs, or you take the patient in a deeper plane?
So no, pharmacological. So first of all, there are two in this process. The two things you are going to be determining. First is what is your comfort level at which you're going to basically allow the blood pressure to go up. So it's about 20% of the baseline. Once you have that, if the blood pressure goes up above your comfort level, then what I would do basically use labetalol or esmolol rather than using your inhalation anesthetic or opioids. That is because you use the right drug for the right reason. You use inhaled anesthetics or if you're using TIVA, for basically providing amnesia and unconsciousness. You're going to use opioids for analgesia or antinociception. If you do use opioids to control that blood pressure, you're going to be over-narcotizing the patient. So when deflation occurs, now the patient's got too much opioid on board. So I would recommend that we use labetalol or esmolol, some sort of vasoactive drug, rather than opioids or inhaled anesthetics. So there has to be communication from the surgeon. Typically, what I would need from the surgeon is you're going to be finishing in about a few minutes, right? Yeah, so what I do is just be prepared. If you are using anything but desflurane, then you would be titrating down. So if I was to use sevoflurane, I would be titrating down my sevoflurane. That's not what we are going to do here. As soon as that last pin comes out, we are going to turn off our inhaled anesthetic, that is desflurane here. And so it's off, you turn off the desflurane, turn off nitrous at the same time. The blood gas coefficient of nitrous and desflurane are similar. And yes, off nitrous. And increase your flows to 10 liters, 8 to 10 liters per minute. Maintain the ventilation so that your aim is to wash off the inhaled anesthetic. Let's look at the twitches. How many twitches does he have? Can you, yeah, just the number of twitches. Is it working? It's that's your tetanus. Okay, stop. Yeah. So you got post-tetanic, but we didn't have before. Yeah. So obviously he's still deep with muscle action, and that's the thing. That's why I would have given only about 30 milligrams of atrocurium. I know you gave more because he was coughing a little bit. So now what the decision making comes as to reversal, and see the desflurane is off, and the concentration of des is rapidly coming down. The bis is coming up, and let's just. Yeah, see the max. So that shows how fast desflurane is washed off. And actually, we can take this off. You have neostigmine glycopyrrolate. So the dose of neostigmine for somebody, let's check the twitches again, please. Let's check the twitches again. The monitor somehow is not working that well. So he's got about 2 twitches, right? 3 twitches, 2 to 3 twitches. So the dose of neostigmine is dependent upon the number of twitches. Ideally, if you had the trainer-4 ratio, that's even better. But let's say you don't have the trainer-4 ratio, then the dose of neostigmine is dependent upon the number of twitches. If you have all 4 twitches with no fade, the dose is 20 microgram per kilogram ideal body weight. If you have all 4 twitches with some fade, it's 30 micrograms. And in my presentation, I will share with you where that's coming from. It's not arbitrary, it's based on randomized trials. If you have 3 twitches, then basically what you're going to do is give 40 micrograms per kilogram ideal body weight. In this case, it's about 2 to 3 twitches, so you could give 40 or 50 microgram per kilogram ideal body weight. His body weight is ideal body weight is 68 kilograms. How did we calculate? He's 168 centimeters, and ideal body weight is height in centimeters minus 100 for males and height in centimeters minus 105 for females. So he's about 68. So we're going to calculate, and you can round it up, just say 70 for calculation purposes, multiply by 30. So 2.5 milligrams of neostigmine and equal volume of glycopyrrolate. You get it in combination, right? Yeah. Yeah. Yeah, take him off the ventilator. Let him breathe spontaneously. Yes, slowly. So as you notice, neostigmine, as you know, has a slow onset. So I would have given neostigmine a little bit earlier on. Obviously, we got a little distracted here in calculations, but he should be coming off.
Too much of disturbance.
At least attempting to breathe. Is he attempting to breathe? Yes. He's attempting to breathe, and that is a sign that he's really waking up. Yeah. So don't forget, just keep ventilating gently. He's opening his eyes. Yeah, but he's weak. So desflurane is off. Obviously, he's a little weak from the muscle laxant, and that's the important part, which I'm going to emphasize again, is that quick recovery is a package deal. Less opioids, less muscle laxant, appropriate reversal, and desflurane. But if you just do desflurane and don't do the other 3, you're not going to see that quick reversal or quick recovery. But we are still good because he's not finished his procedure as yet. Don't forget to breathe, because we want to wash off.
Good for the change.
Let's see the twitches. Still a little weak. So as you notice, you see he's attempting, he's obviously weak from the muscle action, there's no question. And that's typical, they wriggle that tongue, they do this, the movement, so we know that, you know, it's a little bit weak from the muscle action. And he got 50 milligrams of